Thank you, Ben, for that lovely introduction. I'm going to do something different. I hope I don't shock you in the next 2 minutes. What we're going to do is you'll see me playing a few roles here, and I'll be alternating between roles. So right now, I'm Layla, a 34-year-old having her first baby, been in labor for the last 12 hours or so. This is her first baby, and she's been in spontaneous labor, and she's probably going to deliver soon. So that's me, Layla, for now, okay? I need to push! Can I push, please? I'm the midwife. That's all right. Okay, Layla, just relax, breathe, just breathe, deep breaths, okay? Let me check if you're ready, okay? Let me see if the baby's ready to come. I'm the midwife, I do the exam. Okay, Layla, looks like you're almost there. Your cervix is fully dilated, and that baby is coming down really low, +1 station or so, so it doesn't look like you're far. But I'm a bit concerned about the baby's heart rate, because that looks like it's getting a little abnormal. I'm Layla's partner. What's happening to my wife? Come on, do something. I think that baby's heart rate doesn't look good. I'm really, really worried about her. Layla, are you okay? Can't you see she's in pain? I need to push. Can I just push? I do need this. Please do something. Help me. I'm just going to do a check, okay? I think we need a little bit of help here. So that's me, Layla. I forgot the clicker. I'm just checking here, okay? Let me check, see what's going on. Maybe the baby needs a little bit of a hand. Can we just get the doctors soon, okay? I'm just going to get some help here. Can you please ring the emergency buzzer, Resident James? Okay, I'll call the obstetric consultant. I think it's Dr. Arunaz today, and the neonatologist. I think it's Dr. Ben. I'll go and ring the buzzer. We're still in the role, so reserve the applause for later. So, look, my name's Dr. Arunaz. I've got this woman, okay, I've got Layla, who's having her first baby. She's 39 weeks pregnant, and she's been in labor. The baby's showing late decelerations, and I'm really concerned about her, so I think I need to do a vacuum.
The middle of rounds, though.
Yeah, I know, it's 8 in the... Look, she'll probably deliver in the next half an hour, 40 minutes. Can you just hang around in the background? I'll see if I need to do a vacuum.
You want to call me when you're ready, or should
No, just hang around, because I don't know if you... Can you just hang around there? Because
I'll stick around for a few minutes.
Yeah, but look, I don't know if I will need you or not. I'm not sure. Okay. This is obviously not going too well. But thank you, Ben, for your excellent acting. Okay, this is what brings me to our topic today. So I'm going to talk about our global obstetric and neonatal emergency simulation experience. And I've never done this before, by the way. I've played one of those roles each time, and each one of those, but never all of them. So this is like a first new thing for me. As Ben mentioned, I've got a PhD in interprofessional simulation, and that's been the topic of my research for the last decade or so. This is the OneSim program, which is an acronym for the Obstetric Neonatal Emergency Simulation that was started by myself and Atul Malhotra, who you probably know, who's sitting here in the audience. Atul, do you want to just wave at everyone? Okay. So he's a neonatal pediatrician, and we started this, and I'm also married to him, incidentally. So we started this about a decade ago. And that journey's been brought us to where we are now. So essentially, we've got a set of learners here, and we've got the learners here are the obstetricians, the mother, of course, who's giving birth. Sometimes we involve community members as well, the midwives, medical students, midwifery students, nursing students, neonatal pediatricians, anesthetists, emergency physicians, and all those who are involved in births in any form. And it's been interprofessional in the true sense. So what it means is that we've got facilitator team also that's interprofessional, as in We've got the obstetricians and the midwifery educators, pediatricians, anesthetists, nursing educators. So we try to bring them on in their facilitation role as well. Just to take you back, what interprofessional education actually means. So I'm just sort of give you a little bit of a technical definition here. So IPE is, it actually means a way of teaching in which health and social care professions learn with, from, and about each other in a meaningful way to improve collaborations and patient care. And I think most of you are familiar with interprofessional, but remember there's a difference between what we call IP and multi-professional. And interprofessional means actually integrating that learning, so it's not just putting people together in one room and just helping. They all learn different things. Here they are going to learn with each other as well, but also about each other. And there's a lot of hidden objectives there. Some of it is in terms of developing that respect or understanding of what others do. So there's different ways in which we can use IPE. I don't just want to stick to interprofessional education. I also want to bring in the concept of distributive simulation. And simulation, as you're all aware, can be used in different forms and ways, but the ones which we particularly work through OneSim is what happens is this is a realistic, accessible, and a portable simulated environments. Remember the adjectives that I'm using here: realistic, accessible, and portable, rather than expensive or very high fidelity or anything that sticks in a sim center. And I will show you what I mean in the next few slides. Because what we want is a more contextualized, immersive training environments, and something that triggers the response from the clinicians or those involved in team-based learning. And the focus is on the human factors that actually impact our learning, and through teamwork, communication, leadership, and all those crisis resource management skills that we learn about. And being a qualitative researcher, sorry, getting a bit heavy on that, there has to be a theoretical underpinning. And for us, it's been a reflective practice through Kolb's cycle. Just to very briefly break it up for you, Kolb's cycle talks about that there is we have a new learning that, so there's concrete experiences, and then there's that you learn from something new. But then there's reflective learning. So you actually think about what have you learned and where, and then there's abstract conceptualization, which means you will think about where does this fit in? Where does this new learning fit in with what I used to know 2 days ago? And then you create an active learning environment and try those new things, and then the new learning becomes old learning, and the cycle continues on from there. There's a lot of things about Albert Bandura's social learning theory as well, which, again, I do not have time to go into deep dive, but learning takes a lot of forms and involves that you can learn by observing. If I'm doing something right and I see others follow me, then obviously that's good. Evaluative, if it's showing good results, surely it's good. And reinforcement, it worked yesterday, it's going to work today as well. Motivation, and if I keep practicing over and over again, I get better, and that's improving my self-efficacy. So these are some concepts of learning that we hinge upon our OneSim program. Again, it's got this train-the-trainer design, and as you saw, what we just demonstrated in a very in a way that's not high fidelity by any means, but just to give you a snapshot, just normal labor, obstructed labor, shoulder dystocia, fetal distress, resus, PPH. But main reason is for us to demonstrate how, what can actually go wrong and how can we prevent those situations in real life by simulating them. And a lot of these scenarios that we use have actually been usually encouraged through our experiences and inspired from real case scenarios as well. So we try to use more and more. And I will go, just so that you can take home a few things, I will go through a few principles that you can apply tomorrow in your learning environment, or whether you're training juniors. So some of those principles are crisis resource management that you're aware of, communication, prioritization, allocating resources wisely, escalating as necessary, and recognizing what are the limitations to one's own practice. But there are, and just one thing I wanted to say was you can use this in different health professional contexts. Main focus has to be learner-centeredness, though. It is really important that we always have learner as the key to whatever we do, whether it's medical students, nursing students, or applying to different healthcare settings. Maybe in a tertiary hospital, it's going to look different, as Ben was obviously very reluctant to come out of his ward rounds, or if it's a primary care setting, maybe there's other things that it's difficult for them to resource, and so it can vary in situations. Lower middle income group, there are places where it's just healthcare providers, not even doctors that they have, and yeah, I've got a few slides showing that. So main point is to consider a simulation that's fit for purpose, because you might have a different learning objective. You may just have a issue here that, I was just trying to show that we may be, having resource issues, and resources means human resources as well, that people don't have time for situations, and so you can mimic how to efficiently work through those. Or if you're teaching a newbie, for example, medical or nursing students on resuscitation, then it's got a different purpose to it. You're acquainting them with something that they haven't seen. So you can tailor that situation in an interprofessional setting, bringing that realism, which is not expensive, not quite user-friendly, and adaptable. And so these are few points that I'm just sort of taking you through. For example, consider you're teaching a group of medical and midwifery students or nursing students. How would this differ? I mean, you could use the same scenario that Ben and I enacted upon, and maybe use a confederate, because a new person would not be able to figure out, well, what are the steps of birth. So you can assist them and take them through that journey, and they can learn with you by frequent prompting and simple scenarios, and a guided supervised learning. Even procedural and haptic learning is something that has been very helpful in these situations. So again, as I said, the learning objectives can be different. Another aspect to consider would be authenticity. Now, I know US has so many sim centers, and it's, I've been in awe of the work that comes out of here. However, sometimes you may want to step aside from a sim center and consider, is this situation better to be enacted in a birth unit, where the real situation happens. The pictures that I've got here actually are from different situations, some of them on the birth unit and others from sim center. And if you are able to create that, like for example, if Ben's going to come from his neonatal unit and it's going to take him 10 minutes to walk out of there to the sim center while birth unit's next door, then maybe we are better off simulating on the birth unit. So it depends on how to maintain that realism, and that try to stick to as close to real life as possible, because that's what we want to achieve. And remember, with simulation, it actually means that we all shed that disbelief that this is happening is a false situation. I know we didn't quite have that realism in our initial, but I just wanted to give you a snapshot. However, in a real sim, where we have in the one sim, we create that realism in the room, and we don't need very expensive equipment. So this is exactly the equipment we have, whether we are in a Monash Health or Monash University setting in Australia, or going to a little village in India, or in the Pacific, or in Malawi, and so many places where we've run this, and our colleagues who've been running this. We've got a big team, though. It started off with Atul and me, and now we've got a lot of people who are, but as you can see, little bits and pieces. By the way, we do get stopped on the airport a few times. and I have to explain what these body parts are doing there. So there's, this is prompt flex simulator, and that can actually become, like you can do lots of procedural things on it, as in a obstetric simulation of, shoulder dystocia. It's got a swivel arm, so you can do a 360-degree movement of simulating shoulders getting stuck, and mothers bleeding to death. I mean, we try to not bleed them to death. We try to stop the bleeding before. And that's very important, psychological safety of the learner. That's another important aspect of sim that, yes, I'm not touching upon. But really, you have to be careful, because the most important person here is the learner. So you need to think about their safety first, as like that's paramount. But that adaptability or creating that scenario, so this is like a setting in India, and you can see bagging and masking happening on the image where Atul is trying to teach them. And they don't have the resus cots or anything. It's bag and mask. But so you stick with it, fidelity, use whatever is available to you, whatever resources are there, and stick with the real equipment, real people who are going to be there. And you can see me there trying to teach birth to a group of health professionals, and some of them are just, they're birth attendants. They're not doctors or midwives, but they are the ones who are actually conducting the birth, and they'll be alone. I do recall this incident where I asked this person to examine, and I said, okay, put your gloves on. And she goes, well, what do I need gloves for? I'm like, wouldn't you use gloves in a birth setting? They're like, no, we don't use gloves here. And so, I realized, I mean, sometimes, you're on a very different platform as the learner. So you kind of need to change whatever simulations that you're having. And maybe that person, all that person took back was that she needs to wear gloves next time she examines, or, so sometimes your learnings can be very different from what you think it might be. And you can see there's a huge crowd in some of these pictures, but we've simulated with like groups of 20 or large group simulations as well sometimes, and then divided them into little groups to teach. So you can make it adaptable based on the groups that you've got, and where you are, what you. This was in a classroom, for example, in a meeting room, because that's all that primary health center had. I mean, we were lucky to even get that, really. A lot of times it's in the back of the car or somewhere. So, that adaptability is really important. COVID happened, and we had to change what we did. We had to, we wanted to keep this OneSim program alive. And to keep that alive, we innovated, and we tried different ways of making it run. So we were able to, that hand that you can see on the side, that's my son, who's now 19, holding a gimbal stabilizer. So what he's doing is, while I'm playing the role of the mother, in my whole PPE, that was the COVID times, of course, and someone's doing the birth, he's actually broadcasting it live. So we did that straight from Australia to India, while they're learning, because that was the only learning they were getting at the time. And so we were able to, we published all of these experiences, and you can find that on our OneSim website. But here, the learning pedagogy is a little different, because as you are demonstrating, you're not learning by performing examinations, you're learning by observing, which is a different learning method. So with the learning pedagogy, how we run this online, and we still do a bit of hybrid now. So OneSim, when Atul and I are running the OneSim at Monash, what we are doing is, we've got few people on the screen, few people in action. We are broadcasting all of that live, and then the scenarios, the learning happens from the trigger question discussions. And then you can put them in little breakout groups. So we've done that with some medical student groups overseas, and medical and nursing. You put them in mixed groups. You've got a medical doctor and a midwife or a nursing educator, who are the facilitators. So we try to keep it as interprofessional as possible, and then have those trigger question discussions in terms of, we actually deliberately make some mistakes when we are simulating, so they get some idea on what's happening that's not good. And then remember cultural responsiveness. When I'm doing this in India, I'm not dressed up like this. It would be very different. And using the same language, or having someone who's from the community partnering with you so they can try and keep the scenarios as real as possible. Just a summary at the end. So the few concepts that I think are key to making it work is contextualization. What are the learning objectives here? Always keep the focus on the learner and think of what they're getting out of it. Keeping it authentic in whatever ways we can, feasibility, and adaptability as well. Trying to move and those simulators that I showed packed in suitcases do this really well. And you can create a whole room of simulation with just a few people and some plastic models. You do not need the highly expensive technology-based simulators. And of course, applying different pedagogical learning methods by observation and reflections. And please do remember cultural responsiveness as a point. So just to my concluding slide, please do think of OneSim. Either join us, or you can invite us in your centers. We'll be very happy to do a demonstration, either online or real life. And Atul and I will be very grateful. We want to expand the team, and we are trying to keep it as global as possible, so hoping to expand upon this. Thank you.